You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is part 2 of a 3-part series in Murmurs in Children. Today we'll talk about pathologic murmurs and how not to miss them. Last time we talked about the innocent or benign murmurs of infancy and childhood. They're soft, short, systolic, and asymptomatic. You hear them a few times and your brain is just wired not to worry. Now, just to set our minds at ease, all we need to do to pick up a pathologic murmur is just to listen with intention. If you take the time, really just a moment, you're not going to miss them. They're harsh, holosystolic, ongoing, or diastolic. Something will jerk you out of going through the motions. You know, that ritual of listening to the chest, expecting to hear the 100th normal heart for the day. You've heard umpteen normal hearts, and that pathologic murmur will strike you as odd. With that fear and angst out of the way, let's dive deep into the strange and unusual. It can be really confusing to try to commit things to rote memory. It's just too much esoterica. I say we use a physiologic foundation for our approach. Don't worry, I do have a little memory aid, a little ditty to bring it all together. Of course, we do need to do a focused history and physical. Ideally, you know what you're listening for before you place the stethoscope on the chest. But sometimes what you hear is a surprise. You think, what is that harsh sound? And then you think, well, where am I hearing this harsh sound the best? You think for a moment, remember your differential, and then you listen for that specific entity. Does it match what I'm suspecting, or does it not? Now, here is the truth bomb. If you remember this, everything else falls into place. Systolic murmurs are superiorly stenotic and inferiorly insufficient. Once again, you are noting where and when you're hearing that murmur. If you hear a murmur in systole, say in the upper sternal border, think systolic murmurs are superiorly stenotic. If you're hearing a systolic murmur in the lower sternal borders, think inferiorly insufficient. Systolic murmurs are superiorly stenotic and inferiorly insufficient. Diastole is diametrically diabolical. Let's unpack this. So superiorly, you have your aortic and pulmonic valves. Systolic murmurs are superiorly stenotic because in systole, the murmurs you hear are aortic stenosis and pulmonic stenosis. Inferiorly insufficient because if the murmur is heard in systole, then that means that you're hearing the inferior valves, the tricuspid and mitral valves. That sound is there being insufficient. The tricuspid valve and the mitral valve can regurgitate in asystole or be insufficient. So in systole, the inferiors are insufficient. Murmurs in systole include tricuspid insufficiency and mitral insufficiency. So, systolic murmurs are aortic stenosis, pulmonic stenosis, tricuspid insufficiency, mitral insufficiency. Diastolic murmurs are diametrically diabolical. Basically, diastole is the diabolic opponent. Everything that is systolic is the opposite in diastole. So diastolic murmurs then include aortic insufficiency, pulmonic insufficiency at the upper sternal borders, and tricuspid stenosis and mitral stenosis at the lower sternal borders. Diastolic murmurs are always diabolical, always malignant. Now that we have that baseline stuff down, let's get into the nitty-gritty. You're listening up at the right upper sternal border, and you hear a murmur. It's loud, so not reassuring. What was that? Systolic murmurs are superiorly stenotic. It's systole, so stenosis. It's the aortic area, so aortic stenosis. In adults, aortic stenosis is an older person who develops calcium deposits on the aortic valve over time, and the wear and tear presents with slow onset dyspnea, angina, and even syncope. In children, it's almost always going to be a congenital lesion, something they're born with, but the time of presentation can vary dramatically. Only 20% of the time will aortic stenosis in children be associated with other congenital abnormalities. So the majority of the time, aortic stenosis occurs all on its lonesome and can show its little ugly head whenever it wants to. Supravalvular aortic stenosis in children can be isolated, but supravalvular is often the one that is in a relationship with some other syndrome like Williams syndrome. Valvular aortic stenosis is the more common one, and that's the one that is more variable in age and presentation. Subvalvular aortic stenosis is less common, and it's associated with the Schoen complex. The point here is that aortic stenosis is so variable in presentation that it may come to you as a stable child who's already diagnosed and maybe even optimized before surgery, or in a little infant who comes in cardiogenic shock, but we think it's septic shock, we give a lot of fluids and we make him worse. Or maybe it's the teen who just doesn't feel that his exercise tolerance is that great lately. All these vague symptoms, or maybe even syncope. It all makes you think twice about all those faint-hearted teens who seem well when you see them, right? In children, you won't see the typical arterial pulsus parvus et tardus, or the prominent jugular wave like in adults. You may feel a precordial systolic thrill and an S4 in older children. The classic ejection click is present in pretty much everybody. You hear a low-pitched crescendo, decrescendo systolic murmur. You establish a line, get a chest x-ray, and EKG. Infants will be very sick, and you know what to do. Children and teens may fool us because symptoms can be vague. If you have an older child with dyspnea or dizziness or syncope, and you hear this, then he or she needs an echo now, or at least before going home. This is a case where your ears can save a life. Next patient, you're listening at the aortic area. Fine, you move on to the left sternal border over the pulmonic area, and you hear it's a systolic murmur at the pulmonic area, a superior area. Systolic murmur, superior position, pulmonic area. Systolic murmurs are superiorly stenotic, so pulmonic stenosis. Okay, we're halfway there. Now, why does this child have that murmur? Pulmonary or pulmonic stenosis, just like aortic stenosis, can occur above the valve, at the valve, or below the valve. Supravalvular stenosis is not common. Valvular stenosis is the most common type, and like aortic valvular stenosis, can occur by itself or with other cardiac findings. Infundibular stenosis, below the valve, is usually in association with some other congenital heart disease. If the child has a normal intraventricular septum, so no VSD, no mixing of blood, is truly a previously healthy infant with only pulmonary valvular stenosis, that child will also present as a young infant in extremis, but not in cardiogenic shock like the baby with aortic stenosis, but in respiratory failure and cyanosis. There is just low blood flow to the pulmonary circuit and oxygenation is compromised. In children with other associated defects, you'll hear something else, an additional loud murmur that represents mixing of poorly oxygenated blood with well-oxygenated blood. Right to left shunt, as it were. Where have we heard this before? A systolic stenotic murmur at the pulmonic valve, and what sounds like a loud VSD. Let's just throw in an overriding aorta and a right ventricular hypertrophy while we're at it, and you've got the four-pack, a tetralogy, as the cool kids would say. You may diagnose this in the ED in the young infant who is dyspneic, blue, with a pulmonic systolic murmur. I would be very impressed because that kid is going to be sick, tachycardic, and there will be sufficient noise in that room to make it hard to hear. I only bring it up because this snapshot should not make sense. Why is this previously healthy child now suddenly looking like a massive PE, for example? You may try gentle fluids to maintain preload and a nasal cannula or high-flow nasal cannula to help with oxygenation, but try to be as less invasive as possible if pulmonary stenosis is your main concern. If you have to intubate, make sure preload is optimized. Not too much, or you'll tucker out that hard-working right ventricle. Use minimal PEEP. Remember, that right ventricle will be very sensitive to decreased venous return from positive pressure ventilation. This is a little bit of a scary presentation for us. A less acutely scary presentation is the preteen who just doesn't want to go to PE anymore at school and maybe has vague symptoms of dyspnea or easy fatigability. It's kind of blown off as laziness maybe. But isolated pulmonic stenosis is not uncommon, and again, it's totally variable in presentation. Again, this is where listening to the parents, listening to the patient, and carefully to the chest may help guide investigation and treatment, which can include, in this case, balloon dilatation, valvuloplasty, and even valve replacement. You're seeing now a toddler who has a week of cough and intermittent fever. Okay, that's fine, but he doesn't look so good. He's tachypneic, maybe a little dehydrated. He's febrile, he's tachycardic. Okay, maybe he'll perk up with an antipyretic. His fever improves, his heart rate a little bit, but now you hear a holosystolic murmur. Maybe it's even a grade 3. It's not quiet. It's not soft. It's best heard at the left lower sternal border. Is that an S3? I don't know. This isn't what I was expecting. You examine him carefully, and he does have hepatomegaly. This child is in heart failure. You get a line on him, chest x-ray, EKG. He has multifocal pulmonary opacities. That doesn't make sense in this healthy boy. Okay, you got to get to thinking about this one. Fever, tachycardia, multiple infiltrates, endocarditis. He goes hypotensive, and his murmur is now worse. Rapid sequence intubation, stabilize, empiric antibiotics to the PICU. It all happens so fast, you're trying to put it all together when it hits you. Systolic murmurs are superiorly stenotic and inferiorly insufficient. Left sternal border, that's the mitral area, mitral insufficiency or regurgitation, and now it all makes sense. Those chordae tendineae took a hit, probably from infectious endocarditis, and that's a whole other story as to why. This child was probably just unlucky. There's no risk factors that were found. Of course, in an adult, an acute mitral regurgitation is mostly a post-ischemic event. They are very sick, just like in this case. When you hear a presumably acute mitral regurgitation or insufficiency, you can try to stabilize medically, but this patient will need a surgeon sooner rather than later. A 12-year-old boy was visiting family out of the country on their ranch, and he got kicked by a horse. He went to a local hospital there, got some x-rays, some pain control, and the family decided to come home early to see you. He had ongoing pain that acutely worsened today, and now he's having a hard time catching his breath. You see a boy in distress with established ecchymosis to his epigastrium, to his lower chest. He's tachycardic, borderline SpO2, but normal perfusion for now. Chest x-ray was remarkably normal. EKG shows a right bundle branch block and a few PVCs. You go back to listen to his chest and really listen. With some analgesia, he's a little slower now, and at the left lower sternal border, at the tricuspid area, you hear tricuspid regurgitation, or tricuspid insufficiency, is rare. Either it's congenital and diagnosed very early on, or it's traumatic. In this case, the swift kick by the powerful horse's hind legs caused enough of a reverberation through the chest cavity to rupture a papillary muscle. This can be seen in poorly restrained motor vehicle collisions as well. Now, let's compare and contrast acute papillary rupture on the mitral valve versus the tricuspid valve. In the previous case of the toddler with endocarditis, he had mitral insufficiency, and so was in worse shape. When the left ventricle contracts, it expects the mitral valve to close shut so that the blood can be expelled through the aorta. If the mitral valve is insufficient, the left ventricle expels blood in both directions, affecting the stroke volume of the left ventricle and resulting in poor systemic perfusion. In this case of the boy who was struck by the horse, his tricuspid valve is insufficient. He will present more indolently with increased shortness of breath and right heart failure symptoms. It's a subacute presentation, hours to days, rather than the acute mitral insufficiency in minutes. An echocardiogram confirmed the tricuspid insufficiency, and the boy underwent median sternotomy and tricuspid repair and annuloplasty. He did well, but I don't know if he ever went close to a horse again. Diastole is diabolically diametric, so just the opposite of the systolic murmurs we discussed. In diastole, we have aortic insufficiency and pulmonic insufficiency. In diastole, we also have tricuspid stenosis and mitral stenosis. Aortic and pulmonic insufficiency or regurgitation, they're relatively rare and they usually don't occur by themselves. Very, very broadly speaking, most aortic or pulmonary insufficiencies are asymptomatic throughout childhood if they have isolated findings. As older children, adolescents, or young adults, they may start having vague symptoms of decreased exercise tolerance, fatigue, or dyspnea. These are the cases where we have time to figure this out, usually as an outpatient. There's such variability in presentation, and it's not too common. Let's just focus on what you may hear, just for completeness' sake. Aortic insufficiency, or regurgitation, is a diastolic murmur heard best at the right upper sternal border. Pulmonic insufficiency, or regurgitation, is also a diastolic murmur. Sounds very similar. The really only tip here is where you hear it, the left upper sternal border. I think the biggest message with these diastolic upper regurgitant murmurs, the insufficiency, is just don't blow it off in the child or adolescent who has chronic and possibly worsening vague symptoms. He or she may just need an echo. Systolic murmurs are superiorly stenotic, inferiorly insufficient. Diastolic murmurs are diabolically diametric, the opposite. So when you hear a murmur in diastole over the left lower sternal border, that means mitral stenosis. Mitral stenosis can be congenital, but that's pretty uncommon. The majority of cases of mitral stenosis are acquired and usually after rheumatic heart disease. In the 1920s, in the United States, rheumatic heart disease was the leading cause of mortality for children. That just blows my mind when I think about how far we've come, to the point where acute rheumatic fever in the US and other developed countries is exceedingly rare. Now, it still exists in other countries, of course, and anyone who comes to you having grown up or having visited from another place really needs to be evaluated. But to be honest with you, I see this more in adults who've grown up in that other country. Maybe it's not diagnosed or there's some other access to care issues. They present with chest pain or palpitations or chronic cough or various other symptoms. But for completeness sake, let's just listen to this diastolic murmur at the left lower sternal border, mitral stenosis. Valvuloplasty is sometimes an option, but usually by the time patients are symptomatic, they get a mitral valve replacement. Tricuspid stenosis is even rarer and mostly caused by rheumatic heart disease as well. Here's how this diastolic murmur sounds. Let's talk now about a few murmurs that are hopefully caught in childhood, although I'll tell you, unfortunately, we catch these sometimes much later with much higher morbidity. What is this? You hear it best at the left upper sternal border. There's a widely split fixed S2. This is caused by a left to right atrial shunt. We hear it mostly in systole, although you may hear a softer diastolic rumble as well. This is a hole in the atrial septum, so of course you're going to hear it rush around on both systole and diastole, but mostly in systole. Classically, there is a ventricular cardiac impulse or a parasternal heave. An atrial septal defect, an ASD, is an opening in the interatrial septum. This causes a left to right shunt, which overloads the right atrium and so the right ventricle. There usually aren't a lot of people who have symptoms when they're little. It's the chronic changes that cause trouble later. If the ASD is not repaired when the person hits his or her 20s or 30s, you'll start to see pulmonary hypertension, heart failure, or dysrhythmias. Whatever the age, they should be repaired as soon as feasible. Well, I think you know where I'm going to go now, right? ventricular septal defect. Traditionally, these are categorized as membranous, muscular, malalignment, subpulmonic, AV canal. I just can't keep all of that straight in my head, and frankly, it doesn't change how I look at them or what I can do for our patients with them. Let's keep it clinical, let's keep it real, let's keep it practical. A VSD is either small, moderate, or large. A small VSD is usually benign and it closes on its own by age 2. Moderate VSDs may close over time, but they're at risk for non-closure and left to right shunting. Sometimes these can be managed medically. Large VSDs need repair as soon as feasible within the first year of life. Otherwise, there will be permanent changes to the pulmonary vascular resistance. So, how do VSDs present? Prenatal ultrasound will mostly pick up large VSDs, and small to moderate VSDs may be missed. A small VSD will not usually give symptoms. You may just pick it up incidentally. Moderate to large VSDs, if not picked up earlier, can present in heart failure or even earlier than other forms of infant heart failure, as early as a few weeks of life, with tachypnea, poor feeding, poor weight gain, tachycardia, hepatomegaly, all of the things that you would see in right heart failure. Remember, the right heart is getting overloaded by that left to right shunt. You may feel a thrill at the left sternal border. A small VSD, say in an infant, may be a blowing, harsh, holosystolic murmur at the left lower sternal border. A moderate VSD is similar. A large VSD may be tricky to hear, paradoxically. As the right ventricular pressure increases to deal with the left-sided pressures, the two sides equilibrate, and you may not hear much of the characteristic holosystolic murmur. The only thing left behind is that soft diastolic rumble. That is a problem. The message here is that if you hear a holosystolic harsh murmur, you gotta make sure this is a known thing and that someone somewhere has a plan in place to look into it and to deal with it. If you hear this and there are symptoms, for sure this is an admission, and for sure this patient needs another echo and titration of meds before surgery is planned. One last bonus track, a truly pediatric murmur, is the patent ductus arteriosus, the PDA. This is usually in premature infants, and it's almost always dealt with at birth. They can get closure, or they can do a wait-and-see approach. We're not likely to hear it, to be honest with you, as an outpatient, but just for completeness' sake, let's take a listen. Pathologic murmurs are harsh, holosystolic, or just plain, diabolically diastolic. Think, when in the cardiac cycle am I hearing this murmur, and where do I hear it best? Put them together, and what do you got? The mantra. Systolic murmurs are superiorly stenotic and inferiorly insufficient. Diastole is diametrically diabolical. When in doubt, look at the child as a whole. How is he presenting? What resources you have? And when in doubt, get more hands on deck. You can't understand without truly listening. Remember, until next time, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.